I'm just waiting for the Facebook live stream to start, and here it is. So guys, welcome. The discussion that we are doing today is about the arrhythmias, and within the arrhythmias, and I look on this side to make sure that the Facebook live is working okay. We are talking about the arrhythmias today, and this lecture is about the ectopic rhythms. So let's start. Again, I don't have any disclosures after that. What is an ectopic rhythm? An ectopic rhythm is a rhythm that is generated by something other than SA node. So in normal situations, SA node is the one that generates impulses which traverse through the heart and create a heartbeat. If for some reason SA node is not able to generate the impulses, or some other part of the heart becomes overactive and takes over the SA node, and if SA node can produce 70 beats per minute, that thing starts producing 100 beats per minute and bulldozes the SA node, then that will be called an ectopic rhythm. Ectopic means somewhere else. So the causes, please keep this in mind. There are two basic causes of the ectopic rhythms. One is either we have an ectopic pacemaker, that is SA node is a normal pacemaker, but some other part in the heart, AV node or some irritated part of a ventricle which may have an ischemia or fibrosis or calcification or a myocardial infarctive area, some part in the heart other than the SA node starts generating rhythm. So that is called the ectopic pacemaker. Or we can have a recurrent impulse, reentrant current. And I have discussed that, the pathophysiology of that in detail in a separate lecture. I will add that lecture to the EKG course. At this time, we'll just do a very quick review of what is a reentrant current. But just to give you an idea, let's say that this is a normal tissue size. Let's say this is the normal tissue size where the impulse travels. Sometimes when the heart is dilated, impulse takes so long to travel that by the time it reaches back where it started from, that area has become non-refractory. What that means is it has become available for another impulse, and the impulse just goes on it, and that becomes a re-entry. Of course, that causes arrhythmia. Now look at this. This is the normal situation where the SA node is present somewhere in the right heart, right atrium somewhere, right? It is near the superior vena cava, and that is where it sits and generates the normal rhythm. So here in this diagram, you can see that little dot. The ectopic rhythm is when there is something else. In this diagram, sort of AV node is shown. So this one is the AV node, and this is now has taken over. Why has it taken over? Maybe SA node is damaged, or maybe there is some activity on the AV node and AV node has become hyperstimulated. Maybe there is some irritation over there. So this is the ectopic pacemakers. That is the first reason for arrhythmias or ectopic arrhythmias. Now, what are some of the causes that can cause? So clinically, when you're receiving a patient who may have ectopic rhythm going on, ectopic pacemaker going on, what are the possibilities? So most important thing which I want you to remember forever is digitalis toxicity and beta agonist toxicities. Both of them are very common. Digitalis is given for the congestive heart failure. Congestive heart failure is a very prevalent disease. So it is possible that digitalis or digoxin levels have increased so much that they've created toxicity, or potassium levels have reduced comparatively and digoxin has become toxic. Similarly, asthma is a common problem as well, and people who are on beta agonist with the asthma, they can also develop ectopic pacemaking because of the sympathetic overdrive. Now, just very quickly, what is the mechanism of action of digitalis toxicity? How does the digitalis toxicity occur? So let's look at that very quickly with a diagram. So what happens is, let's say this is a cell, this is a cardiac tissue cell. Of course, this tissue cell has sodium and potassium, potassium ATPase pump, right? And you remember that sodium goes in normally. When the cell depolarizes, sodium goes in, right? Then what is the function of this pump? The function of the pump is to throw sodium out and bring potassium in. So that is the recovery of the cell's action potential or the ionic balances. Now what happens is, digitalis competes for potassium binding sites on the ATPase pump. This is what is really, really important. So when digitalis comes and sits down here on these places, let's say here, when digitalis sits down here, what will happen? It will block the pump. When the pump is blocked, then what will happen? Sodium will be trapped inside the cell. When the sodium is trapped inside the cell, it would open up the calcium channels. Calcium channels cause calcium to come in, which will cause more calcium to be released from the endoplasmic reticulum, which will cause increased contractility. So that is one effect of digitalis, increased contractility. That is why we actually give it to the congestive heart failure patients. Other problem that it causes is that it somehow increases vagal tone. Parasympathetic activity is increased by digitalis, which then means that conduction system will become suppressed under the vagal tone. The conduction of electrical current in the heart will reduce. Heart will not receive the current timely in various tissues, and the heart can undergo arrhythmias. So that is the primary mechanism by which digitalis toxicity can occur. Now, why does hypokalemia increase digitalis toxicity's threat? Here is the deal. Digitalis competitively binds with the potassium channel, potassium sites. If there is less potassium, that means there are more chairs empty and available for digitalis to sit on, and digitalis would cause the ATPase pump to become blocked. So can you actually use that for a management of a patient? Yes, you can actually increase potassium level in a patient who is suffering from digitalis toxicity, and that increased potassium will come and displace digitalis from the sites where it is sitting and sort of reduce the digitalis toxicity. So that is one way of actually treating digitalis toxicity. Now, how do you manage the digitalis toxicity? There are so many important things to be done just from a high point of view, from a high level. Number one, of course, stop the digitalis administration if that is going on. Number two, arrhythmias that have occurred, make sure that the advanced cardiac life support protocol is initiated and you start taking care of the arrhythmias. Give intravenous fluids to try to wash out the digitalis. Now, one thing, that do not give calcium. Normally for the arrhythmias one can give calcium, but an arrhythmia of digitalis toxicity, and if you administer calcium, you can actually end up killing the patient. So it can be fatal. Intravenous fluids are also given to maintain the bring the hypotension back, because heart is in a compromised state. And then most important thing is that you give digitalis FABs or the antibodies that can go and bind with the digitalis and remove it. Digibind is the name that is used normally. Again, I do not have any association with any of those. I just wanted you to know this, because in the case, in serious situation, it is important to have it handy. Now, second cause of the ectopic arrhythmias. That second cause is the reentrant current. So in this diagram, look at the first diagram, the first A circuit, and what's happening here is that the current is coming from one direction, then somehow it splits in this tissue, and by the time when the impulse reaches here, the tissue is in the refractory state and it just continues on. So it is a unidirectional movement. However, sometimes when the heart tissue is in compromised state, if it is ischemic, it is infarctive, there is a calcium there, there is a calcification there, there is a fibrosed piece there that is irritating that area, and that can cause the the impulse to travel slowly. So imagine now that the impulse comes in from here, and when that impulse reaches and splits on two sides, one side the impulse has become very, very slow. Meanwhile, the impulse on the other side that went on to the remaining heart also turned back. And then by the time it reached here, this impulse has died down, and the new impulse that is circling has a chance to become reentrant. And so that would cause a cyclic movement, and that is called the reentrant arrhythmia. It can happen because of a tissue injury, ischemia, infarction, fibrosis, calcification, so healed area can cause this, or it can be caused by a dilated heart. In a dilated heart, impulse takes longer to span the heart, and it is possible that when it reaches the same place where it started from, that tissue has become non-refractory and the impulse can become reentrant. Again, I've done this in detail, about 1 hour long lecture about the reentry, so I can't do that all here, but remember this, that reentry can cause arrhythmias. That means people who have infarction or ischemia or other such damages or mechanical things in their heart, they can actually end up having reentrant arrhythmias. Now, what are some causes of the reentry? As I just said, ischemia, fibrosis, irritation by external mechanical objects, or irritation by calcified plaque or some infective area or some fibrosed area, kind of irritating the things around it. Now, what questions to ask when you are working with the arrhythmias? What are the questions that you should ask when you're looking at an EKG? What are the things that you should see? We need to become masters of the EKG, right? So let's see, how do we understand? So first thing is, there are 3 P wave questions to ask, 1 QRS complex question to ask, and 1 EKG regularity or the rhythm question to ask. So here, please remember this: 1, 2, 3. 1 rhythm question to ask, then 1 question to ask about the QRS, and 3 questions to ask about the P wave. So it's not 1, 2, 3, it is 1, 3. Okay, so what are the 3 P wave? P wave is your friend in this situation when you are expecting a rhythm problem. So before we talk about it, keep this in mind, that a normal sinus rhythm means P wave starting from the atrial depolarization, then QRS complex indicating ventricular depolarization, and then T wave indicating ventricular repolarization are the normal structures present in the EKG. Now, if for some reason there is a problem that the SA node is not working, that is what arrhythmia is, right? SA node is not getting a chance to do some ectopic thing, or some reentrant mechanism is working. What do you think will happen to the P wave? It really depends. So look, if the impulse starts from here and impulse travels downwards and P wave is upward in lead 2, then if impulse travels upward, then the P wave will become inverted in lead 2. So one important thing to keep in mind, P wave's axis will become disturbed with the arrhythmia which are of ectopic in origin. Axis of the P wave, number 1. Number 2, presence of the P wave. If let's say SA node is not working at all, let's say atria is not contracting at all, then do you think the P wave will be present? No. So P wave's presence will be also important. Then P wave and its relationship with the QRS complex. If atria are working independently and ventricles are working independently, then the P wave might actually get buried in the QRS complex or under the T wave, or just be randomly going on. So 3 questions to the P wave: what is the axis of the P wave? Then what is the P wave present or not? And third, what is the relationship of the P wave to the QRS complex? Then of course one question about the QRS complex itself, and that is it wide or not? A wider QRS complex means a slowly beating heart, which means a ventricular, possibly a ventricular rhythm. So if the QRS complex has not become wide, just keep this tip in your mind, please. If the QRS complex has not become wide, you still have supraventricular pacemaker. It may be AV node, or it may be SA node, or somewhere in the atria, but the pacemaker is still above the ventricle, or there is some problem with the ventricle that it is driving fast, but that is rare. Okay, so let's look at the P wave analysis. Look, normal P wave in lead 2 is upward, and we have discussed this in the past that the P wave has 3 parts. So if you see here, the P wave has 3 parts. The first 1/3 of the P wave is representing of the electrical activity in the right atria. Last 1/3 of the P wave is representing the electrical activity in the left atria. Middle third of the P wave represents electrical activity in both atrium. This is what is your friend. And especially with the V1 lead, you know that in the V1 lead, and I've done that in the past, the P wave is biphasic. Right atrium is upward and left atrium is downward, because V1 lead looks at the heart this way, and this is the right atrium and this is the left atrium. So they are opposite to each other, so it is biphasic. So how do you say that the P wave has the correct axis? Upward deflection in lead 2 and biphasic in lead V1. Keep that in mind. So we are seeing that here. And in the diagram here, if you see, this arrow is the lead 2, and then as the current moves in the similar direction, P wave is upward in lead 2. Here, check this out. This is a normal P wave. So here, do you see that the P wave is upward? P wave is upward, lead 1 and 2. Here, this is lead V1. Do you see biphasic? Of course, it is tiny, but you can see that small upward deflection and then small downward deflection. That is the biphasic P wave. Now, P wave axis analysis. Let's continue this discussion. Here, in this case, this is a pathological situation. And what is that? Look, the AV node is generating the nerve impulse. That means that the electrical current is now moving backwards. That will simply mean that the P wave will become inverted. So inverted P wave means the axis has become changed, means SA node is not working. That is your clue to say that we may have an ectopic rhythm going on. So look at this diagram. In this diagram, the P wave is inverted. Now, P wave presence, that is the simplest analysis. Look at the P wave. Is it present near the QRS complex or not? Now, sometimes P wave is present, but it is dissociated, and so it ends up under the QRS complex or T wave. So you have to look over there, and you have to look in a stretch of the EKG. But normally, if before the QRS complex, the line is isoelectric, then the P wave is most probably not present. And if that is not present, that means atria are not beating, or electrical activity of atria is not being picked up. Now, how do you say that the P wave may be buried somewhere, or actually P wave is not present, or the atria are not creating impulses? Simple. QRS complex. Is the P wave missing? Let's say yes. Now look at the QRS complex. Is it wide? That means ventricles are working, atrias are not working. If it is not wide, and what does wide mean? 1.2 milliseconds. If the QRS complex is equal and lesser than 1.2 millisecond, it is not wide. If it is greater than 1.2 millisecond, it is wide, and if it is wide, then there is some problem with the atrial side, and definitely ventricles are working. So see here, this is my depiction of a wide QRS complex. And again, note there is no P wave over here. Now, this is an example of a missing P wave. Junctional tachycardia. What does that mean? Junction, that is AV node, is sitting at the junction of atria and ventricle. When AV node is working and causing tachycardia, if you see here where I've circled it, there is no P wave. Do you see? There is no P wave there. Excellent. So I hope you can see that. Let's continue. And look, this is narrow QRS complex. If QRS complex was wide with the absent P wave, you'll say where this rhythm is coming from the ventricle. Here the QRS complex is narrow. That means it is still supraventricular. P wave is missing, so it is probably the AV node that is doing this work. Now, P wave and QRS relationship analysis. P wave and QRS relationship analysis. So guys, as we continue with this discussion, I'm going to turn the Facebook Live off. Please look for the complete lecture that will be at the Dr. Bean. Thank you.